So welcome everybody. Thanks for joining me tonight. A big shout out to our tech team for managing things and trying to keep us online and making things going smoothly. And a quick shout out to for Moni's in the chat. Feel free to post any questions that you have along the way. And if I can't answer something, he will probably try to help answer it. And if you put the question in the chat, we have a better chance of being able to get you the answers if for some reason I can't answer, there's not enough time to have a big discussion about something. So remember, I love to hear what you're all thinking. So unmute and share. I really love that. We learn from each other, including me. I know a little about a lot, but you guys teach me every day too. So how about we get going? This presentation covers essential aspects of comprehensive care, focusing on hygiene practices, mobility assessment, skin integrity, pressure injuries, client positioning, and strategies to help you succeed in your NCLEX exam. Each section provides foundational knowledge and practice tips for effective patient care. Today's agenda, we will explore several key areas. First, the importance of hygiene practices in patient care. Next, how to assess and support mobility. Then we will discuss skin integrity and pressure injuries, followed by effective positioning techniques. And finally, some strategies on how to pass your NCLEX and some practice questions. I think everybody's favorite part, including mine, because I get to hear what you're thinking. Hygiene practices. Hygiene is a fundamental aspect of patient care, crucial for promoting health and preventing infections. Proper hygiene practices can significantly impact patient outcomes. Bathing and skin care are essential for maintaining skin integrity and preventing infections. It is important to assess a patient's needs and provide assistance when required and ensure comfort and dignity. I always want to say, make sure you're asking the patient to do as much as they possibly can, allowing them to be an active participant in their care. Skin integrity is crucial to prevent infections and, of course, ensure overall health. Assessing patients' needs for tailored care, that's kind of the taking in what they can and can't do and recognizing it. As far as bathing and their skin care processes, asking them what they do at home, if they happen to have dentures, how do they care for them at home, what do they use to soak them in, do they have that with them, making sure we have that accessible to them should they have been admitted or had an unplanned admission to the hospital. They might need some of the denture soak, the containers, or the tablets, or whatever it is that we may need to provide in the hospital. Monitor when you do your skin assessments, when you're providing patient bathing and skincare, make sure you're always assessing. Monitor for skin color, texture, breakdown, any kind of injury, odor. Pressure points is a big one. Their skin turgor. Are they getting enough fluids at home? And maybe you'll notice that they're not, and you can start that conversation with them as well while you're doing their skin care. Monitor for temperature. Maybe you don't know they have a fever and they haven't said anything, but you might actually be able to tell when you're doing their skincare and their bathing. Also make sure you're looking for any injury from tubing in use, especially oxygen tubing. I tend to think that one's probably one of the worst ones. Maybe an NG tube, although I don't think those are quite as bad, but oxygen tubing gets all tangled up because it's longer, it's under the pillow, it's under the sheets, it's under their arm, it's under their legs. Making sure that they aren't getting a pressure injury as a result of laying on that tubing, creating a pressure point. Ensuring comfort and dignity, extremely important. It's important to provide assistance that respects the patient's comfort and their dignity, making bathing a positive experience. But embarrassment should not interfere with the need to meet the patient's needs or make an assessment. There's different types of baths. We have bed baths, partial baths, sponge baths. I always call it the bath at the sink. There's also the chlorhexidine wipes. I think they're doing a lot more of that these days, but all of them, regardless of which one you're doing, should include a skin assessment. I had to chuckle when I read this. Bathing with soap and water in a basin is no longer used due to bacteria growth in a basin. Back in the day when I was doing a million bed baths for patients. I'm a total germaphobe, so it always made me a nervous wreck that we were reusing those basins. The only thing I could hang my head on was the fact that our soap was bacteriostatic. All right. Understanding skin conditions. The slide highlights key factors that put patients at risk for skin conditions. Immobility, big one, right? Poor nutrition, moisture, they're probably the most significant contributors to skin breakdown. Nutrition does play a really crucial role. A lot of times we get patients who are not eating well at home, or they're not eating well while they're in the hospital. These conditions, such as like diabetes, can further implicate skin integrity. Additionally, friction from the sheets and medical devices should be monitored to prevent injury. When you're boosting your patients, make sure that you're not causing that shearing motion under them when you're moving them, or when you're rolling them from side to side if they're not quite as mobile. Try to avoid the shearing motion and that friction. Just some things we kind of already talked about. Poor nutrition impairs skin health, making them vulnerable. Diabetes can cause changes in skin integrity and healing. They typically heal the slowest. Moisture from incontinence can contribute to skin irritation. So make sure after cleaning patients up, and or if their gown gets water spilt on it or what have you, that you're giving them dry sheets, dry pads under them, and a dry gown if for some reason they end up spilling on their blankets, their gown, or their sheets. And then, of course, friction, like we talked about. Alzheimer's, dementia, and altered level of consciousness and memory issues. I put that in there because I think it's important to remember that those patients don't typically recognize the risks that are associated with, perhaps laying on their oxygen tubing, or the fact that being incontinent can create skin irritation or skin breakdown. So those things are to be thought of when you're taking care of your patients if you happen to have somebody with one of those illnesses as well. I think sometimes we overlook those things, thinking patients have an understanding, but maybe their capacity really isn't there. Skin breakdown can lead to various complications, including pressure ulcers caused by sustained pressure on pressure points in the skin. Infections, such as cellulitis, may enter through broken skin. Additionally, a dermatitis can occur due to the moisture and the friction, while compromised skin is at risk for fungal infections as well. Delayed healing can also occur and result from factors like poor nutrition and insufficient blood circulation. Remember, fungal infections thrive in damp, compromised skin. And dermatitis, same thing. Cellulitis arises from broken skin. Foot and nail care. I just want to throw out there that I do have some red on the slides. When you see that, I think it's important and worthwhile to pay attention to. Usually that's the part that I will reiterate to you when I'm looking at these slides. Proper foot and nail care is vital, especially for patients with diabetes or limited mobility. Monitor for signs of infection or injury, and make sure you're educating your patients on self-care techniques. So, importance of proper care. Proper foot and nail care is crucial, particularly in patients with diabetes and peripheral vascular disease or limited mobility. To prevent complications of infection due to neuropathy, especially associated with the diabetes, feet should be washed and dried completely. Make sure you're drying between the toes too. Apply lotion as well, but usually just on the bottom and the top, not between the toes, because that creates that warm, moist environment where you make the perfect conditions for infections to grow. Never ever soak or trim nails on a patient with diabetes or peripheral vascular disease, or obviously if there's an open wound or any kind of breakdown of the tissue in the feet. The primary care doctor or a podiatrist should be consulted to trim nails. Now, I know in the hospital where I worked, we had an awesome wound care nurse. And if we had patients that required any kind of specialty foot care, specifically nail trimming, if they were diabetic or had peripheral vascular disease, she would come down and she would take care of everything that needed to be done as far as trimming their nails and assessing any kind of open areas. So make sure that you're putting in accounts out for that if you have that at your hospital. And letting patients know that they shouldn't be doing that at home as well. It's a good opportunity for education to let them know that they should be seeing a podiatrist. And usually, depending on their insurance, most of the time it's like Medicare or something along those lines. Podiatry is covered for nail care and trimming of nails, and I should say foot care and nail care, because it's for both. It's usually covered by insurance companies to make sure that they're taking care of their feet. A lot of times they can't feel those things because of the neuropathy. I actually know patients who would step on their insulin the needles at the top of the insulin syringes. If they would break them off, they would step on them and they would have no idea that there was even that tiny little subcutaneous needle in the bottom of their foot. Monitoring for infections, regular monitoring for signs and symptoms of infection is critical to maintaining foot health. Monitor for calluses, warts, ingrown nails, fungal infections, examine between the toes, and note any kind of signs and symptoms of cracking or dry disease or dry skin. Assess pedal pulses, their gait, their temperature, and if they feel light touch when you're washing their feet or their skin. Opportunity to educate, I think that's always really important when you're providing bathing and doing their foot and their nail care. Educating patients on self techniques does help empower them. And it's also important to make sure, like I said previously, if they're a diabetic patient or they have the PVD, they should be seeing a primary care doctor or podiatrist for trimming of their nails. But additionally, making sure that they have proper fitting shoes, that they tie or they Velcro or whatever, that they fit well and they don't slop, so that the patients end up, when they walk, they slop, so the patients end up tripping. Another thing that I think is really important, and I think we kind of overlook that because we're so busy in the hospital, seamless socks, especially in patients with diabetes or peripheral vascular disease. It creates pressure points in their shoes if they have thick socks on with thick seams in them. So something else to keep in mind when you're taking care of your patients. That moves us to oral care. Oral care is crucial for preventing oral infections and maintaining overall health. Regular oral hygiene practices help reduce the risk of systemic infections and enhance patient comfort. It also may improve their diet and their willingness to eat. So you notice a little red on the screen. I'm just briefly going to go through this because you probably know most of this pretty well. But I just want to mention that regular oral care is essential. It helps decrease infections. It helps improve their well-being. If you notice they have poor fitting dentures, you might want to ask them about it, ask if they've seen a dentist, mention it to family members, or maybe they'll tell you they have new ones, they just haven't gotten them yet, or what have you. But making sure we're trying to make it the best case scenario for them as far as eating. And then chlorhexidine is used to clean patients on ventilators to decrease venous-assisted pneumonia, which I'm sure you're all aware of. Patients need routine oral care. It shouldn't just be once in a while. It should be all the time, especially those that are unconscious. And of note, you can now buy over-the-counter those oral swabs that you usually give to patients in the hospital or that the nurses are using. They don't clean plaque off the teeth like when you brush your teeth. So if you have patients who are using them, you might want to mention that. It sounds like somebody might not be muted out there. I don't know if everybody else is hearing that or if it's just me. I just wanted to mention that out there. Please make sure you're on mute unless you're sharing something for the group. It just makes it harder for everybody. And it creates this echo, so it's harder for me to hear as well. Dentures should be removed at night. Careful not to drop them, and they should be soaked. And oral care should also be provided for the patient as well. If your patients are often immobile, or you can get them in a wheelchair, you can get them to the sink. Letting them do their own cares is really important as far as their oral cares and getting them to brush the teeth, or swab out their mouths, and letting them help you with their dentures is really important as well. So overall, good oral hygiene is really important. It's linked to better overall health and a reduction in systemic infections. One thing I would also like to mention is if you've taken care of patients who've been undergoing treatment for cancer and they have chemotherapy, they may suffer from thrush, so it may be very uncomfortable for them to be brushing their teeth or rinsing out their mouth. So make sure you're taking a look in there. If they tell you, oh no, my mouth hurts, I don't want to do that, getting them whatever they need to, the medication to help reduce the pain in their mouth, and making sure they're rinsing with whatever they can. You're obviously not going to want to give them mouthwash, but maybe one of those swabs and some water would be enough to help them. Diabetes and drug and ETOH use can also increase periodontal disease. So again, you may see patients with those things that have poor dentures, poor dental care, and they may also have that same issue as patients who are being treated with chemotherapy, where they have pain in their mouth. So keep that in mind and ask patients and include them as much as you can. All right. Eyes, ears, and nose care. Cares of the eyes, ears, and nose includes routine cleaning and monitoring for signs of infection or issues, providing guidance on proper care techniques, and addressing any current concerns promptly is important. Some red on this slide as well. So I just wanted to mention that when you're cleaning the eyes and you're wiping a patient's eyes out with a washcloth, a warm, damp washcloth, make sure that you're doing it from from the inner to the outer when you're cleaning, so you're not putting bacteria in, you're cleaning it from inner to outer. Assess for blinking. A lot of patients have, especially if they're comatose patients, if they have problems blinking, you're going to want to make sure that you're lubricating the eyes so that they don't end up with some kind of damage to the eyes from having dry eye. When you're looking at the ears, doing a regular exam of the canals to evaluate for excess wax buildup. And if you happen to see that, maybe they're sharing with you that they're having a hard time hearing, paying attention to that. Check their hearing aids for buildup as well. A lot of times they'll take them out and set them in their little case, or maybe they'll set them on their bedside table. But you can see that there's a buildup of wax there. That might be a sign that there's a buildup of wax in the ear as well, or in the canal. And letting the physician know so they can get somebody in there to help, or the medication drops to put in there to help dissolve the wax. That will be helpful, or recommending follow-up when they get out of the hospital. Important monitoring signs of issues. Assess patients with any tubing, oxygen, nasogastrical tube, or a vent for skin breakdown routinely. It should be done with every assessment that you're doing. Hair care and shaving. Hair care and shaving contribute to personal hygiene and patient self-esteem. Make sure you're asking them, offering to help. Usually we have razors on the units so that you can help patients with shaving. You can always ask family members to bring in a patient's electric razor if they have one. If they want to use their own, that's always a good thing to do. Provide assistance when they need it, and respect their privacy if they wish to manage it on their own. Proper hair care is essential, especially when maintaining personal hygiene, but especially in a comatose patient, their hair mats so easily. So make sure that you're combing it or brushing it regularly. And I know a lot of times in our ICUs, we had those, they're like a shampoo bag. They used to do that fancy little plastic thing on the bed and you could wash patient's hair, but I know now that they have these, like it's like a bag that you can kind of wash a patient's hair, and that will help prevent decrease in this matting that happens. Shaving for hygiene, electric clippers or razors for those on blood thinners, antiplatelets, or scheduled for surgery. Honestly, I think we typically use electric clippers and razors in the hospital more often than we use the regular razors, just to help prevent any kind of cuts or scrapes, which could be an open area, allowing for bacteria to enter. Respecting an individual preference. Understanding and respecting grooming preferences is crucial when you're taking care of patients, especially in hair care and shaving. Make sure you're evaluating skin and assessing for alopecia and pediculosis capitis, which is like head lice. So make sure you're checking for those things as well, and getting treatment if it's something that you happen to come across. Assessing mobility is critical to developing a comprehensive care plan. Mobility affects overall health, and understanding a patient's capabilities allows for tailored interventions. Mobility assessment involves evaluating a patient's ability to move independently. This includes observing their gait, their balance, and any assistive devices that may be needed. A lot of times patients will bring their walkers in from home, which is wonderful. Just make sure to take a look at it and make sure it's properly fitting and it's at the right height. It's usually about the top of the greater trochanter or at the hip if it's easier to remember that. Make sure it has the 4 little rubber feet on the bottom. Just taking a look at things, and a lot of times in physical therapy, you can have those things replaced or recommend to family or to the patient that these things need to be replaced if for some reason they're ill-fitting, or maybe they're due for a new walker. But you can replace the wheels and you can replace those little rubber feet at the bottom. So we're trying to make sure that our patients get the best and the most optimal care as possible while they're in the hospital, but we also want them to thrive when they go home. So if we happen to identify something when we're assessing their mobility, it's prudent to make sure we do everything we can to make them successful. Independent movement evaluation. Assessing a patient's ability to move independently is very important. Gait observation, we should be doing this all the time when our patients are moving. Make sure you're looking at their gait, and if you notice that they're having trouble with balance or any kind of abnormalities or potential fall risks, evaluate the need for an assistive device. Maybe you have a patient who is admitted who doesn't have a walker, and they came in with something like vertigo. And so they're having a little bit of a struggle with walking, and now maybe they need a walker. So you can work with physical therapy to have them fitted and get an appropriate walker. The height of a walker and a cane should be at the greater trochanter or like hip level. Use a gait belt as needed. When I was working in the hospital, everybody got a gait belt unless you were independent and walking completely on your own. Make sure that you encourage the patient to look up and out. They should look in front of them to make sure there's nothing in the way, as should the nurse, to make sure there's nothing that's going to create a fall risk, right? And we should definitely be standing on a patient's affected side, no matter what assistive device that they're using, but specifically walkers and canes and crutches for that matter. Make sure that the patient is using the walker appropriately. Let them know that they should be looking up, make sure there's nothing in front of them that could be a fall hazard and that they can see where they're going. Make sure they have their glasses on. Make sure they're clean. Make sure the patients are moving the walker first. That's why making sure their little feet or their wheels are appropriate so that the walker's not cattywampus on them, creating more of a disturbance and a fall risk for them. Make sure that you're, like I said, walking on their affected side. Canes should also be 4 to 6 inches or so from their feet and can have like a flex in their elbow, like 15 to 30-degree flex, so that they're walking with a little bit of flex and it's not tense, creating a possible potential for a fall. Nurses should stand on the affected side when when a patient's using an assisted device. Watch for safety concerns like water or objects in the pathway. Ask them about their home. Do they have rugs in their bathroom? Do they have rugs in their kitchen? Encouraging them to move them, pick them up because they are fall hazards. Again, verifying those little rubber feet and that they're fitting right on the bottom of the walker. It's also an opportunity to do a little bit of a balance assessment and make sure the patient's stability and that they're balanced when they're taking steps. Maybe you identify something and they say to you, oh yeah, I get dizzy every time I stand up. Oh, okay, now we have another issue we should be looking at about identifying those symptoms and sharing them with the physician so we can look into what may be causing that. Maybe it's as simple as they have an ear infection or their glasses aren't clean or they haven't replaced their glasses in, 6 years. So maybe they need an eye exam. So it could be some very basic things. But this is our opportunity to make sure that they do really well when they get home. I just put this slide in here just to sort of show you what the height is. And it should be like hip level, or it's technically the top of the greater trochanter, which is where this is. So making sure that their walkers and their canes are properly fitted. That's really the point of this slide here. I thought maybe a visual would be helpful to help you remember. And then use of canes and walkers. Canes and walkers provide necessary support for patients with limited mobility. It might be temporary. It might be long-term, but it may be temporary. Proper fitting is important. And I think we've pretty much covered why that's important. Asking patients how they navigate their surroundings at home, picking up rugs, is really important as well. I think we pretty much covered most of that. Complications of mobility. So, or immobility, my apology. Pressure ulcers, muscle atrophy, venous thromboembolism. These things can all be complications: cardiovascular, tachycardia, bradycardia, orthostatic hypotension. All of these things can be problematic for patients who have mobility issues, especially if they're using, a walker or a cane. Pressure ulcers. Prolonged immobility can lead to those pressure ulcers, and they're very painful sores that develop in the skin. Sometimes it happens at home because patients are sitting too long because it's too hard for them to get up, or maybe they don't have the help they need at home, or maybe they just don't feel well enough to get up at home. Immobility can cause muscle atrophy, and it happens very quickly. From your patients that end up in the hospital and they are admitted for a couple of days, if they're not up and moving, you can just see the muscle basically wasting away right in front of you. They get really atrophied and they get very weak very rapidly, and they end up having to go to long-term care or short-term rehab from the hospital, even though they were independent at home, just because of their immobility for a couple of days because they were sick. Muscles weaken and they shrink due to lack of use. We all know that when we stop exercising because we're sitting and studying for hours on end, the first time you get up and go back to exercising, you're like, wow, it feels like it's been a year and it's only been a couple of days. Blood clots, inactivity, becoming sedentary for any type of reason, but especially immobility. Patients can develop thromboembolism, which is a serious condition from blood clots. The other thing I just wanted to mention, I know I talked about the tachycardia and the bradycardia and the orthostatic hypotension, but paying attention to those things when you get patients up and you're taking them for their walk. Do they get dizzy when you sit them up at the bedside? If they say they do, check their blood pressures laying down, sitting, and standing, and then call the healthcare provider and let them know, hey, the patient complained of this is what I did, and this is what I found. They may also be being treated for bradycardia. And so you may have patients who are on medications for having low heart rates. You need to pay attention to that as well. Or tachycardia. Maybe they get really short of breath and their heart rate goes up with any kind of movement. They're really sensitive to that. So again, just things to think about when you're taking care of your patients, especially the ones who are immobile. Let's talk a little bit about crutch walking and crutch gaits. So proper techniques for crutch walking can enhance mobility for patients requiring assistance. Understanding different crutch gaits is essential for patient safety and effective mobility. I got to tell you, when I'm the nurse at the bedside, I'm not the person you want teaching you how to walk with crutches. I can hardly handle walking with my own 2 feet sometimes. But there are proper crutch techniques. So learning them and being in tune to them is very helpful. Proper height adjustment and grip is critical on your crutches. You going upstairs, patients should move the unaffected leg first and then the affected. Moving downstairs, you should move the crutches first and then the affected leg. Can you imagine trying to go up steps and put the crutches up first? A visual on that probably makes you realize that that's probably not going to work, right? And you're probably going to end up with a head injury because you're going to fall down the stairs. Understanding crutch gaits, nurses should again stand on the affected side. So there are different gaits, different crutch gaits, such as the swing to and swing through, which I think I have a slide to follow this that talks about those specifically. We had physical therapy in the hospital and they were available most of the time. So they were very helpful in working with our patients so that they were doing the right gait depending on whatever their injury was or their issue was. Patient safety is paramount when using crutches. Awareness of their surroundings and their maintaining good balance is essential during their mobility. Encourage them to look up and out and never rest their arms on the axilla pads up here because you can cause damage to your brachial plexus. And I've actually seen that and it's really, really painful. I just put this in here as a visual so you can, when you think about it, when you think about somebody on crutches, you think, oh, don't don't rest your arms in there because you're going to end up with damage to the nerves. Injuries to the brachial plexus can lead to varying degrees of impairment, and injury can be sustained by resting on the crutches. So again, just a visual to help you remember. Here's the gaits I was talking about. So you have a 2-point gait, a 3-point gait, a 4-point gait, and the swing through gait. We can quick look at them. So for a 2-point gait, it's for clients who can bear weight on both legs and have mastered the 4-point gait. So the procedure itself is the crutch on the affected side and the unaffected foot are advanced at the same time. 3-point gait is for clients who can bear weight only on one leg, and the client bears weight on both crutches and then on the uninvolved leg, repeating the sequence. You can see where you would probably have to practice these things in order to try to teach somebody these things. The 4-point gait for clients who can bear weight on both legs, the right crutch is advanced, then the left foot, then the left crutch, and then the right foot. 3 points of support are on the floor at all times. And then the swing through gait is for clients who have adequate muscle power to balance the arms and the legs, commonly used by clients with paraplegia who wear supporting braces on their legs. And this weight is placed on the supported legs. The client places the crutches one stride in front of them and then swings through while they support their weight. I have seen this used the most, to be honest with you, and the 2-point gait. So, all right, let's talk a little bit about skin integrity. Maintaining skin integrity is critical in patient care. A thorough understanding of factors that affect skin help prevent complications and promote healing. Skin is the largest organ in the body. I'm sure you all know that. Several factors impact skin integrity, including moisture, friction, and circulation. Regular skin assessments can help identify at-risk patients. Like I said, any opportunity to do their cares, you should be doing a skin assessment. Moisture levels play a crucial role in maintaining skin integrity. Avoiding excessive moisture and dryness is really important. Friction and shear forces can damage the skin. Using those lift sheets, making sure that you're being very careful and you're not shearing things under them. Even the sheets when you're rolling patients back and forth, to change bedding if you have to, because it leads to very significant skin breakdown. Proper nutrition. If you know you're taking care of somebody who's malnourished, you already know they've got one check in the box for the possibility of breakdown. Deficiencies can impair the skin's ability to heal, and so they heal a lot slower. Circulation importance. Adequate circulation and oxygenation are obviously important for delivering nutrients and oxygen to the skin, which promotes healing, which maintains skin integrity. So it all kind of goes together. And I'm sure you all know this, but I wanted to put this on here anyway because I think it's just important to remember, and you may end up running across this at some point. The Braden scale is the assessment tool that you generally use in the hospitals. It's pretty common, and it's used to evaluate and predict pressure ulcer risk. There's some other ones out there. Every place I've ever seen pretty much uses the Braden scale, and it's routinely used with all assessments to identify risk. Wound classification. So there's different types of wounds. They can be classified as acute, chronic, surgical, each requiring specific strategies. And they all have different characteristics and different healing processes. Understanding these is important. The importance of classification. So classification refers to the cause, the status, and the severity of the wound. Phases of wound healing. Wound healing consists of 4 essential phases: hemostasis, inflammation, proliferation, maturation, each playing a critical role. Hemostasis phase is initial phase where blood vessels constrict to reduce the bleeding and a clot is formed to protect the wound. That's why you never rip off Band-Aids, because you're probably ripping off the clot, right? Inflammation phase involves immune response to prevent infection, clear debris, and lead to healing. And then we have healing by intention, and that's probably the thing we're going to talk about the most here. Healing by intention refers to how a wound is healing based on the treatment approach, such as primary or secondary intention. Understanding healing intentions. Primary intention involves direct closure of the wound, and the dead space is eliminated immediately. Secondary intention allows for natural healing from the inside out with a gradual filling of the dead space. And third, or tertiary intention, is delayed closure, addressing infection risks with irrigation and removal of the debris, and that it is closed later by primary intention once the dead space has filled in. These poor patients require a lot of care, and it's very uncomfortable a lot of times. Pressure injuries are a significant concern in patient care, often resulting from prolonged pressure on the skin. Awareness of risk factors, like the Braden scale, and staging can enhance prevention and management. Here's some risk factors for pressure injuries. You probably could have told me all of these, right? Immobility, moisture control, and nutritional deficits. Immobility significantly increases the risk of a pressure injury due to prolonged pressure. That's why we turn our patients every 2 hours, right? We get them up, we walk them, we get them up out of the room, we get them up out of bed. Avoid massaging reddened areas due to possible damage of capillaries, necrosis, and skin breakdown. Putting lotion on is okay, but if you see a reddened area, you definitely don't want to be rubbing on it, causing skin breakdown. Moisture control from incontinence or sweating can lead to skin breakdown and increase the risk of pressure injuries. Think about your patient who's having trouble breathing, or they're breathing at a kind of a fast rate and they start to sweat and perspire. This is that moisture control that we're talking about. It's not always just incontinence. And then nutritional deficits. Poor nutrition can impair the skin integrity and the healing. How do we manage pressure injuries? Effective management of pressure injuries includes regular assessment, appropriate dressings, and addressing any and all underlying causes. This is an opportunity for education with our patients, and it's crucial for prevention. Regular assessment of pressure injuries is essential. Keeping the skin dry, clean, avoid pressure points, apply barrier protectants if you happen to identify an area that needs it, turn and reposition per protocol, and range of motion if indicated every 8 hours. Make sure that you are checking that tubing when you're getting patients up or when you're moving them or when they're calling you into the room for water, they need an ice water. Make sure you're taking an account of, okay, well, that's where the oxygen tubing is, that's where the NG tube is, and that they're not laying on the tube. Same thing with the SCDs. When you're putting those on your patients, making sure the tubing isn't kinked under them or that the tops have curled over and creates a pressure point. If you do identify something, fix it. If you identify a pressure injury, make sure you're letting somebody know. You get the physician involved, you get wound care involved, and we're doing everything we can to address the pressure injuries. Maybe we have pressure mattresses. Maybe we have wound care doing something. Maybe there's a special protectant, barrier protectant we should be using for these patients. Add it to their care plan so that it's not just you who knows, but everybody on the team taking care of the patient knows. And of course, sharing the information with the patient, if the patient is able to understand, reposition if you start to feel like you're getting uncomfortable, shift your legs, do some ankle pumps, move your feet around, move your arms around. You don't want them doing aerobics in bed, but just to make sure that they're moving so that they don't end up with any pressure points. Another opportunity to remind them, even when they go home. We do all this in the hospital, but we want to educate them so when they go home, they're moving. They're not just sitting either in bed or sitting in their chair, their favorite chair in the living room, watching TV, practicing their muscles to click the remote. Make sure they're getting up and moving, and you're telling them those things and why it's important. Sometimes they just need a friendly reminder and they maybe don't understand. Causes of pressure injuries and stages. Pressure injuries often occur due to prolonged pressure on the skin in areas such as heels, sacrums, and elbows, the three major places you get breakdown. The sacrum's number one. Factors like moisture, poor nutrition, immobility. I feel like I'm saying those things over and over, but they really are the key causes, right? They all contribute to risk. For example, a patient who is bedbound may develop a pressure ulcer on their sacral area due to the constant pressure of the movement or lack of movement. There are 4 stages of staging a wound, but there are 2 additional stages also, and the 2 additional stages are unstageable and a deep tissue injury. So here's a little description. It's kind of brief. Stage 1 is when the skin is intact, but you're starting to see red and dark pigmentation. These are the best ones to identify when you're moving patients because you can prevent further damage by either doing some barrier treatments or perhaps moving them more often or getting them off that area or using pillows and other devices to help create barriers so they don't have a pressure in that particular area. Making sure you're avoiding the friction and the shear forces when moving the patients to exacerbate this particular injury. And then we have stage 2 is where the skin is no longer intact. And oftentimes there's a blister there. It may or may not be open, but in stage 2, you often see a blister already. That's not very much. That's pretty quick. Usually the skin is pink and red, and it's oftentimes it appears like it's moist or wet. But the key with the stage 2 is that there's usually a blister. It may or may not be open, but you'll definitely see a blister there in a stage 2 stage. So stage 3 is a full thickness skin loss. You might see adipose tissue. You might see granulation at the edges. You may see necrosis possible. You can start to see necrosis in a stage 3 wound. It doesn't cover the whole thing, but you might start to see specks of it in the wound. And then stage 4, these are full thickness skin tissue loss, exposed fascia. You might see ligament, you might see bone, and you might see muscle. You may see a lot of eschar or necrosis. It may cover the whole wound, most of the wound. It may not cover the whole thing because I think unstageable is really more where you see the necrosis and the eschar covering the whole wound. And then deep tissue injury, the same thing. It's pretty bad. You can see all of these things and then some. So in a pressure injury, these are obviously the 4 stages, and then we have unstageable, and then we have a suspected deep tissue injury. We can't really evaluate these. It's very hard to know exactly what kind of damage is going on. And that's why it's called a suspected deep tissue injury. This is really about the dressing type and its mechanism of action. And I'm not going to go through it a whole lot, but I found it in the Fundamentals of Nursing, which is a wonderful book, and I'm sure you all are very familiar with it because you just graduated. But I thought it was a great breakdown of what dressing type to use, and so I wanted to put it in there so you could reference it for any kind of wounds, especially like the unstageable wounds. I don't think it says anything more about a lot of times they'll do surgical debridement with unstageable. That's what I was looking for. So you'll be able to tell if they're doing a surgical debridement, it's probably unstageable or deep tissue. All right. Positioning clients. Oops, sorry. I got a little overzealous there. Proper positioning of clients is crucial for comfort and to prevent complications. Key concepts in positioning clients include understanding body alignment, pressure relief, and the importance of frequent positioning to prevent skin breakdown and promote comfort. Frequent positioning, like turning every 2 hours, is important. Encourage ambulation if patients can get up and do that. Get them out walking in the halls as often as you can. Getting them up out of bed for maybe breakfast, lunch, and dinner, and getting them in their chairs helps to eliminate those pressure points. Make sure the linens are nice and neat and no wrinkles. Same thing with like putting SCDs on and TEDs on. Making sure there's no wrinkles to create pressure points or that things haven't folded down. Or they don't have like 6 blankets on their bed because they're cold and half of them are under them and they're in a ball, and so it's creating a pressure point under their hip. Keeping them dry and clean, of course, will help with all of these situation. And then make sure that you're doing frequent assessments whenever you are doing anything with your patients. Pressure relief and frequent repositioning are probably the key here. Various techniques and aids can be supportive in effective positioning, using pillows, using wedges, anything that you can do to remove the possibility of a pressure point is very important. Using specialty mattresses, especially patients who are in the hospital a long time, or if they're comatose, or if they're bed bound, making sure we're using the best air mattresses that we can, or the best mattresses that you have available to you in your hospital for the patients. And if you have suspicion of something, asking the physician for a wound care consult so they can come in and evaluate if that's something that you have available to you. Wow, we're already at strategies to pass NCLEX. So preparing for NCLEX requires regular studying and knowing your strategies and looking for your resources, like being here today and using Naxlex to do your review questions, your cats and your rats, to make sure that you're getting yourself ready. Practicing NCLEX style questions is really important. I don't know if Amanda is on tonight, but she was asking about information about strategy. So I just want to throw out there that we are looking at putting some information on our website. But in addition to that, I did discover that your Sanders book, your comprehensive nursing book that I know all of you have, it actually has I don't know if it's a chapter or if it's just a couple of pages that talks about strategies to pass your NCLEX. So you might want to go back and take a look at that. So practice tests and strategies, familiarize yourself with NCLEX format, making sure that you are answering questions that are aligned with NCLEX questions and those style questions. Practice, practice, practice. I know I say it a million times, but it's the best thing you can do. Understanding the prioritization method and Maslow's hierarchy of needs and using ABCs, knowing your nursing process and assessment is important when you're approaching questions. And process of elimination is probably when you use the most. I know a lot of people are using the true and false method too. Just be careful. Make sure you know what the question is asking. And then watch for distractors in the question and the answers. It's not even just in the questions where they'll throw words in there like we had the other night. Instead of inhalation, it said exhalation. And so it would have been the right answer, except that they threw that word in there. So a distractor. So I just want to remind you, just a quick reminder of those things. You guys are probably tired of hearing me say it, but I think it's important. And so that's why I'm saying it. Active learning. A lot of people learn through practicing in group study, practice, 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 repetition, keep practicing, and then engaging in material, talking to your peers like you guys are talking. Make sure you're communicating with each other. If you have questions, we learn from each other. It's really important, and you benefit so much more than you even realize. Stress management is also important. I know a lot of people get stress anxiety. I know a lot of people who have had a hard time just because of stress management and having test anxiety. So finding something that works for you to help manage your stress before you go in and take your NCLEX is really important, whether it's, taking some deep breaths right before you sit down, whether it's doing some kind of mindful deep breathing, making sure you're getting adequate rest and sleep, especially before you go in to take your NCLEX. I know that's kind of an oxymoron because you're probably nervous, but trying to make sure that you get enough sleep and rest will help your memory function better. It'll help with memory retention during your exam. And then effective time management is really important. It's easy to say, yeah, I'm going to study on Tuesday, I'm going to study on Thursday. Make yourself a schedule and try as best as you can in your very busy lives. I understand, but trying to make time to study. So in conclusion, we talked a lot about importance of hygiene practices, promoting mobility, maintaining skin integrity, and a little bit about effective exam strategies. So what do you say we go ahead and take a look at some questions? Does anybody want to read the first question? You've all been so quiet. I feel like there's nobody out there. Is there anybody out there?
A nurse is teaching a client how to use a 4-point gait with crutches. Which description correctly outlines the gait? A. Move left crutch and right leg together. Then move right crutch and left leg together. B. Move both crutches forward together. Then swing both legs forward together. C. Move the left crutch, then the right leg, followed by the right crutch, then the left leg. D. Move both crutches forward together with the affected leg first, and then the unaffected leg.
Anybody want to take a guess at that one?
Letter C.
Yep, that's the right one. So C is the answer. Move the left crutch, then the right leg, followed by the right crutch, then the left leg. It's the 4-point gait, which involves moving each crutch and leg separately, one at a time. A, B, and C are the wrong answers. So moving the left crutch and the right leg together, and then the right crutch and the left leg together, this is the 2-point gait. And this one is the swing gait, when you swing both legs forward. And then D, moving both crutches forward together with the affected leg first, and then the unaffected leg, that is the 3-point gait. Excellent. Great job reading and great job on the answer. Ready for the next one? Anybody willing? All right, I'll take this one. A nurse is assessing. Oh, go ahead, please, please. You're much better.
The nurse is assessing a client who uses a walker to ambulate. It will require follow-up if A, top of the walker is even with the client's waist. B, client's elbows are flexed at 15 degrees. C, legs of the walker have rubber tips. And D, client is wearing non-skate shoes.
I'm going to take a guess at it.
A.
A?
Yes.
Yes. Top of the walker is even with the client's waist. And A, that's correct. Top of the walker is even with the client's waist. The top of the walker should align with the crease of the client's waist when their arms are relaxed at their sides. If the walker is too high or too low, it can cause improper posture and increase the risk of falls. So B, the client's elbows are flexed at 15 degrees. The proper elbow flexion when using a walker is 15 to 30 degrees. This degree of flexion allows the client to maintain stability and balance. Legs of the walker have rubber tips. Rubber tips on the legs of the walker provide traction and prevent slipping, and it's an appropriate safety feature. And then the client is wearing non-skid shoes. Non-skid shoes help prevent slips and falls during ambulation. Good job. Good job reading and good job answer. Okay. Anybody want to take number 3?
A 72 years old client with limited mobility is assessed for pressure injuries. Identify the stage of the pressure injury shown in the figure below. Stage 3, stage 2, unstageable, stage 4, that is C.
We're saying
It's
it's
a
Unstageable, C. That's not
C.
4.
C. Everybody going with C?
Yeah. Yep.
Unstageable.
Yeah, that's that necrosis in eschar.
Yeah.
That's correct. An unstable pressure ulcer is a type of bed sore that occurs due to prolonged pressure on a specific area of the skin, resulting in lack of blood flow and oxygen. It is a full thickness tissue loss where the depth of the wound or the bed sore is completely obscured by eschar in the wound bed. And stage 3 ulcers have burrowed past the dermis and reached the subcutaneous tissue beneath. Stage 2 have a partial thickness loss of dermis presenting as an shallow open ulcer with a pink or wound bed. It may or may not be open. You may see sloughing or bruising. And, oh, here it says it. It may be present as an intact or open or ruptured blister. That's kind of the key for trying to evaluate which one it should be. Number 2 has the blister in it. And then stage 4 have full thickness skin loss that extends through the fascia with considerable tissue loss. You may see muscle, bone, tendon, or joint involvement. All right, number 4. Anybody willing?
A nurse is teaching a
nurse.
client with diabetes about proper foot care. Which of the following instructions should the nurse include? Select all that apply. A. Change dressing daily using sterile technique. B. Inspect feet daily for cuts, blisters, or signs of infection. C. Soak feet in warm water for 30 minutes. D. Trim toenails straight across and file sharp edges. E. Use over-the-counter corn remover for calluses.
This is one of those questions where it's select all that apply. So we're kind of doing process of elimination, but you know there's probably more than one right answer here, right? And I'll give you a clue, there's 3.
Mm,
What do you think of A? Should
yes.
we do that?
Correct.
Yep.
Mhm.
Okay. What do
A,
you think?
B,
A,
D.
B.
A, B, D.
A, B.
A, B.
B, D.
Everybody pretty much agree with that?
Yeah.
Yeah.
A, B, D. Very good. So A, change dressings daily using sterile technique. If the diabetic has a wound or ulcer in the foot, daily dressing changes using sterile technique are essential to prevent infection and healing. B, inspect the feet daily for cuts, blisters, and signs of infection. Daily foot inspection is a cornerstone of diabetic foot care due to neuropathy, and they may not feel their injuries. And trimming toenails straight across and filing sharp edges is the recommended nail care for diabetic clients. Trimming straight across prevents the ingrown toenails. Soaking feet in warm water for 30 minutes. Diabetic patients should not be soaking their feet. And I don't think I highlighted that in red on the slide about skincare. I think I highlighted it, but I didn't say it. You should not soak the patients who have peripheral vascular disease and diabetic patients because it can cause that skin maceration and increase the risk of infection. And using over-the-counter corn removers for calluses, diabetics should avoid over-the-counter and callus removers as they often contain those acidic chemicals, which can cause damage to the skin. Instead, they should call their podiatrist and make an appointment to be seen. Good job. Good job reading. Good job answering. Number 5.
The primary healthcare provider prescribes management of a client's wound to heal by third intention. The nurse understands that which of the following describes healing by third intention. A, the wound is structured. B, the wound is clean and dressed every day with normal saline. C, the wound is gradually filled by connective tissue. D, the wound is left open for several days for irrigation and removal of debris and later closed by suturing.
Anybody want to take a guess? So third intention was the last one that we talked about. So what do you think about the wound being sutured? That would be like your surgical patients, right? So that's probably not it. What do you think of D?
Correct.
D. Very good. The wound is left open for several days for irrigation and removal of debris and later closed by suturing. Third intention involves leaving the wound open for a few days to allow for debridement, drainage, and irrigation, followed by closing or suturing the wound after infection risk is reduced. Good job reading. Good job answering. Wow, we're at number 6 already. Anybody want to try it? All right. A nurse preparing a client for the insertion of a suprapubic catheter notices that the site is excessively hairy. Which of the following actions is appropriate? A, shave the hair using a razor before insertion. B, clip the hair close to the skin using scissors or clippers. C, apply a water-soluble gel to flatten the hair. Or D, leave the hair as it is and proceed with the catheter insertion. What you think? Anybody want to take a guess?
C.
All right, let's take a look. The answer is B. So clip the hair close to the skin using scissors or clippers. I gotta say, I don't know about the scissors, but clippers, usually that's what you have in the hospital. So clip the hair close to the skin using scissors or clippers. Clipping the hair with scissors or clippers is the recommended practice. It removes hair without causing irritation or micro tears in the skin, reducing the risk for infection. That's why we don't like razors, right? Shave the hair using a razor before insertion. Shaving is not recommended because of skin irritation, micro tears, and the risk of infection, so it's best to avoid. C, apply water-soluble gel to flatten the hair. Water-soluble gel can be used to flatten the hair to facilitate the insertion of the catheter, though it is not a standard step. And D, leave the hair as it is and proceed with the catheter insertion. If the hair does not interfere with the procedure, leaving it is completely acceptable. However, it can increase the risk of infection, so it's typically advisable to trim or clip the area before catheter insertion. Good job reading. Good job on the guess. So number 7, We have somebody who'd want to read this one?
Nurse is caring for an immobilized elderly client. Which tool is recommended for assessing skin integrity? A. Rancho Los Amigos scale, B. Hamilton scale, C. Norton scale, D. Braden scale. I think letter D, Braden scale.
D.
Did somebody say C?
D.
D? Yep, everybody agree with D?
Mhm.
Yes.
That's correct. Braden's scale is specifically designed to assess the risk of developing pressure ulcers. It evaluates sensory perception, moisture, activity, their mobility, their nutrition, and friction and shear. The scale is widely used and recommended for assessing skin integrity in clients at risk of pressure injuries, including elderly and immobilized patients. Do you guys all use that in where you're working?
Yeah.
How about the Norton scale? That's the other one. I'm glad that you guys all knew it was the Braden scale, but the Norton scale also assesses the risk of pressure ulcers. It considers factors such as physical condition, mental state, activity, mobility, and incontinence. So it's a relevant tool for assessing skin integrity in immobilized patients. However, the Braden scale is more commonly used and widely accepted. It's like the gold standard for clinical practice. So the Rancho Los Amigos scale is used to assess levels of cognitive functioning recovering from a brain injury. And then Hamilton scale is the scale for depression in a psychology questionnaire used to measure the client's severity of depression, not for skin integrity. All right, good job, good job reading, good job answering. Come on, anybody want to read number 8?
A client comes to the emergency department complaining of substernal shoulder pain with dyspnea. How should the nurse position the client? A. Left lateral, B. High Fowlers, C. Semi-Fowlers, or D. Trendelenburg. Maybe B. High Fowlers.
How does
No,
everybody
C.
feel about that?
Yeah, should be high faller due to the shortness of breath.
Mm-hmm. Yeah, B.
B?
I-
All right, let's see what the behind the door it says. The correct answer is B, high Fowlers. Yay, good job. This position is sitting upright at 60 to 90 degrees. It's optimal for clients with dyspnea. This position helps maximize lung expansion, decreases pressure on the diaphragm, and enhances venous return, making it easier for the client to breathe. I feel like anytime there's a question that you come across and dyspnea is one of the problems and high Fowlers is in the answer bank, I feel like high Fowlers is almost always going to be the answer, right? So incorrect answers: left lateral. This position may be appropriate for certain conditions, but not ideal for somebody experiencing dyspnea. Semi-Fowlers position is the 30 to 45 degrees, which can provide some relief for respiratory distress, but it's much less effective than high Fowlers. And Trendelenburg is lying flat with the legs elevated. It's generally used for clients experiencing shock or hypotension, and it actually can worsen respiratory distress by putting pressure on the diaphragm.
So I have a question. If
Yeah.
there is no high fowler and there is semi-fowler, it would be better to go for that, right?
Well, say that again. I'm sorry.
If the option for the correct answer in the question, if there is no B there and it's just C, A, D, so better to go with C.
Oh, here, you mean if these were the only 3 you had?
Yes.
Yes.
Okay.
Yes. Semi-Fowlers is, I mean, of the 3, right? It gives the patient the best ability to decrease respiratory distress. So that would be Fowlers or Semi-Fowlers.
Professor, I have a question.
Yeah, go ahead.
I've come across one of a question in the NCLEX practice test. They used the neutral position. Is it the same with the high Fowlers?
Oh, I don't know. I don't know how to answer that question. We should probably check with was it in our content, in our questions?
Oh, not really. I just saw it
Oh.
in a random practice tests.
Okay. So if it didn't give you the option of high Fowlers and neutral, was neutral the answer then?
Yeah, neutral was the answer, and I got it wrong because I didn't know what neutral was.
What was, do you remember what the question was?
No, there was really there was no rationalization, but they just posted the answer that was neutral position. Something like this, a patient has problem with breathing, and one of the choices was neutral position, and they chose the neutral position.
Oh, okay. And there was no high followers for an option or even
Yeah,
some.
there was nothing. I was looking for it, but I didn't find it.
Okay. So, I honestly, I've not heard that one. So that's a really good question. And if you wouldn't mind, if you could put that in the chat, uh, because that way we have a way of contacting you and finding out exactly if that's what neutral means. In my mind, I'm thinking it's equivalent to high foulers or semi-high foulers, but I don't want to tell you the wrong thing. So if you would do that, that would be great. And then we can reach out after we research it and talk to our content team and see why they chose to use the words high foulers as opposed to neutral.
Oh,
That
yeah.
way you'll have clarification then. Thank
Okay,
you.
thank
That's a
you.
really
Thank
good
you.
question. You're welcome. You're welcome. Anybody else? Or otherwise, I'm going to go on to number 9. All right. Can I strong arm anybody into reading number 9? All right. A nurse is caring for a 72-year-old client with a sore on the sacral area. Which of the following assessment findings is a characteristic of stage 2 pressure ulcer? A, redness, B, pain, C, tissue necrosis, or D, blistering? Now I'll let you think about that one. Anybody want to take a guess?
D.
D, tissue necrosis is unstageable.
D. Blistering.
D.
D is the
Blistering.
correct answer. Blister for
Yeah,
stage 2.
dog.
Everybody agrees with D?
Yes.
All right, let's see what's behind the door. D is the correct answer. Blistering. Stage 2 pressure ulcer is characterized by a partial thickness skin loss involving the epidermis and possibly the dermis. It appears as an open or ruptured blister or shallow ulcer. So good job. Redness or erythema is typically seen in stage 1, and the skin is intact, but it does appear red. B, pain. While pain can occur at any stage of the pressure ulcer due to skin breakdown or tissue damage, it's not a distinguishing characteristic of any stage. And then tissue necrosis is characteristic of stage 3 or 4. In these stages, full thickness skin loss and necrotic tissue may be present. It's usually worse in stage 4 than it is in stage 3. Kind of like that picture that we saw, right? But that one was unstageable, obviously. Okay, number 10. Somebody want to read the last one?
A client's central venous catheter accidentally dislodges while they are attempting to get out of bed. The nurse observes blood dripping from the catheter side and notes that the client is dyspneic. What is the nurse's priority action? A, give oxygen 2 liters per minute. B, position in left Trendelenburg. C, notify the healthcare provider. Or letter D, clamp all ports of the catheter. Maybe letter B?
What does everybody think?
Letter B, because what it says priority, like the first thing you have to do before before they get the oxygen or before they notify the provider, and clamping the port is not acceptable without instruction from the ACP.
B is the correct answer. Position in left
Yay.
Trendelenburg. Good job. Head down on the left side. This position helps trap the air embolism in the right atrium, preventing it from traveling to the pulmonary artery and creating a life-threatening condition. And giving oxygen is obviously helpful for the dyspnea and shortness of breath. However, while important, it is not the immediate priority because of possible air embolism, right? And then calling the doctor, they're going to ask you what you did. So that's not the right answer. And then declamping all the ports is important in managing air embolism. However, this action is secondary to putting them in Trendelenburg. I just want to go back to the question because we talk about the types of questions and strategies, and this is a priority question. So all of these things are important, but what's the most important thing that's going to address the fact that the patient is dyspneic? So that's our problem. That's a lot of words, but this is the problem. And we want to know what to do for what's going to help the most here. So obviously putting the patient in Trendelenburg. So just to kind of break down the question a little bit, Some of them will be much more, it'll be more obvious to you, but I just wanted to show you if you break it down. And I lied to you. There's 11 questions, not 10. I apologize. I forgot this one had 11. So I'll read the last one for you. A nurse notices that the client is developing redness around the wrists where the restraints are in contact with the skin. What should the nurse do first? A, apply a cuff liner to the restraint. B, notify the healthcare provider. C, adjust the restraints. Or D, document the findings in the client's medical record. Anybody want to take a guess? And I know it's not even going to be a guess because I know you all know the answer to this one.
C, adjust the restrainer.
Excellent. So the correct answer is C, adjusting the restraints. Anything with restraints, anytime it talks about restraints, you're always going to want to be reassessing restraints, right? So redness around the wrist suggests that the restraints may be too tight or incorrectly applied, leading to friction or pressure on the skin. Adjusting the restraints immediately will help reduce the pressure and prevent further damage. A, apply a cuff liner on the restraint. Cuff liners are padding that can reduce the pressure to prevent further breakdown. While it is a reasonable step to protect the client's skin, it's not the first action. And then B, notifying the healthcare provider should be notified if there is skin breakdown, if the redness leads to actual breakdown, but it is not the first step. And then D, document the findings. It is important to document any skin changes or adverse effects from the restraints. However, it is not the first thing that we should be doing. All right. Success. We made it to the end, A, and success to all of you who have your tests coming up and your continued practice. And thank you for being with me here tonight.
Thank you, Professor.
You guys are so welcome. You guys were really quiet today. That's okay. I'm sure you're all tired and busy and all getting anxious about your test. Does anybody have their test coming up soon?
Yep, I do.
You do?
Yeah.
Good luck to you. I know you'll do fine.
Thank you.
Yeah, you guys will do fine. You always do fine in the questions. Just take some deep breaths before you start taking your test. And remember to always read the question twice. And when do we change our answers? One last question. You guys remember, when do you change your answers on your NCLEX?
Never. Well, we absolutely know it's wrong.
That's right. That's exactly right. That's exactly right. Make sure you read your questions twice and you know what your questions are asking you, especially if you're doing true and false. Okay?
Mine coming on the 29th.
All right, guys. Well, great job. The 29th? Wow.
Yeah.
Oh my goodness. Does anybody have it coming up? Somebody said in the next day or two in the last class as well.
Yeah.
So you guys have a little time to practice. So keep doing your cats and do some rats. You guys, are you liking the questions in there? You feel like they're helping prepare you?
Yes.
Yeah, they're pretty
Yeah.
great.
Yeah, they're really aligned very well with like NCLEX style questions, which is why sometimes I hesitate to answer questions because I want to make sure that the content, those questions are really aligned with NCLEX questions. So I want to make sure that the information that you're getting is really aligned with that because you're taking your tests. Okay?
Thank you. Appreciate it.
You're welcome. Good luck, you guys. Thank you for a great evening, and I'll see you next time.
Thank you. Bye-bye.
Thank you so much, Professor. Yeah.
Thank you.
Welcome. Good luck to you guys.
Bye.
Bye.
From Ghana.
Bye, thank you.
You're welcome.
So you will follow her orders.
Thank you, Professor.
Do that.
Bye, guys. Good luck.